and welcome for this first Meet the PI meeting. We have the chance today to welcome Lambros Tselikas from the Gustave Roussy Institute in Villejuif. As you know, this is the first time that we have this session in ECIO, and the idea here is to highlight some exciting new research programs and to discuss the topic of the research, of course, with the PI, but also to have his experience on establishing this kind of research. Lambros, we are all yours, and I would like to thank also Philippe, which is sharing this session with me.
Hello, thank you very much, Alban. Thank you, Philippe, for the kind invitation. And to start this discussion, I'll show you the general structure of this study. So it's the HIPANIV trial, which is evaluating intrahepatic infusions of ipilimumab, an anti-CTLA-4 antibody, with nivolumab administered intravenously for advanced HEC patients. So just to remind where we were when we started by writing this protocol, it was early 2020. For patients with advanced HEC, the established treatments were for first-line sorafenib, and there were trials on lenvatinib. For second-line, nivolumab was just approved with the first results of the Checkmate 040 trial, and we had some results with pembrolizumab and regorafenib. The IMbrave trial that most of you are familiar with, combining atezolizumab and bevacizumab, was not yet published, but we had some ideas of the benefit for these patients versus sorafenib, and we did not have yet the Checkmate 040 final results evaluating nivo plus EP or nivo cabo or nivo EP cabo, and no ideas for the third lines or the treatment algorithms for these patients. And actually, we are at an era where immuno-oncology is being established for advanced treatment patients, but it's kind of moving towards BCLC-B patients also. So we'll see if this study can have an interest. Those are the results that have been published a few months later. So it was summer last year, showing the significant benefit of atezolizumab and bevacizumab versus sorafenib in terms of overall survival, but also in terms of objective response. So immuno-oncology has a place to be for advanced HEC patients. And those are the results published at the end of last year, showing that the combination between nivolumab and ipilimumab has an interest on patients with advanced HEC on second line for these patients. And what's very interesting is that you have this dose effect of ipilimumab. It's probably one of the immunotherapies that has a significant dose effect, meaning that if you increase the dose, you increase the effect, but you increase also the complication rate. And that's the idea of delivering locally this anti-CTLA-4 antibody just to prime the immune response locally and hopefully have a systemic effect while keeping the toxicity rate quite low. We have done the same things with intrahepatic chemoinfusion by targeting locally the liver disease, but with immunotherapies, we have the hope that this local response will be translated to systemic response. So that's the design. Actually, it's quite simple. I'll show you the inclusion criteria, but we have a 2 weeks screening period. Then it's a phase 1 dose escalation trial with 3 levels, 3 doses of ipilimumab that are being evaluated, 50 milligrams, flat dose, 100 milligrams, and 150 milligrams. And we go 3 by 3 patients. It's a typical 3+3 design. Then we have 3 patients in the 50 milligrams arm. If no complications occur, then we move forward, and so on and so on. And this combined with systemic nivolumab, 1 milligram per kilo, every 6 weeks. So that's based on the dose response that have been published on previous trials for nivolumab. And then, of course, we have a translational program on using biopsies, imaging, and blood sample. And we follow them. The study population was quite simple: biopsy-proven HCC, BCLCC. You need to have an active liver disease because we're delivering the treatment through the hepatic artery. Patients should be eligible for intraarterial approach. They should be after the first line treatment. So at the beginning, it was supposed to be post-sorafenib. Actually, it's both post-sorafenib, but also post-atezolizumab plus bevacizumab. And they should have no previous immune-related adverse events, grade 4, that have not regressed. In terms of endpoint, the primary endpoint was safety. So the treatment adverse events, related adverse events, and we're trying to find the dose limiting the toxicity dose. And the secondary endpoints were, of course, efficacy, and still later on survival, PFS, and OS. And we have the translational research program based on pre and post treatment tissue biopsies with sophisticated techniques to try to evaluate the immune environment, blood samples to have a more dynamic range of what's happening with immunomonitoring and secretome. And also we're trying to implement the ctDNA measurements, and of course imaging. And what's interesting on imaging evaluation, we have the new criteria published last year with the IT-RECIST, the intratumoral RECIST classification, which allows to monitor the injected lesions, but also the non-injected lesions, the anesthetic, the abscopal effect of what we're doing. And we have added an immuno-PET imaging sub-cohort, meaning for the expansion cohort, all these patients will have an immuno-PET prior to the treatment to evaluate the distribution of the antibody and try to correlate it with the outcomes and the other translational results. So just to show you the first patient we have included, it was a patient that had already had a left hepatectomy. She had a quite large right mass of 6 centimeters, hypervascularized. She already been treated by sorafenib, but also by anti-PD-1 and tyrosine kinase inhibitors. And she had, of course, she had also extrahepatic metastasis. So I have done the treatment, and that's the angiogram. So I would like to thank, of course, ECIO for having me with you today, and all the multitude of persons that have helped to put this together, meaning that our MDT, digestive MDT, our immunological team, and all the sponsoring and the statistical teams and all the supports we have in Gustave Roussy. So thank you very much, and we can discuss and on the outcomes on this study. Thank you.
Thank you. Very interesting study for sure. So if I understand well, it's a phase 1 study, but does it include a pharmacological part to evaluate the biodistribution, the systemic exposure to the dose that you inject? And do you have some preclinical work supporting that when you inject directly in the hepatic artery, you will get a higher intratumoral concentration?
So thank you, and it's a very interesting and difficult question to answer. So actually, we've planned to keep some samples, some plasma samples, to be able to do some pharmacokinetics. As you probably know, it's quite difficult to dose for these antibodies, as the formulation and the protein sequence is not known to everybody. So you need to develop tests to be able to capture the systemic exposure. So, but we have done that with other trials. and I think we'll be able to dose the systemic ipilimumab. Of course, we won't dose the intratumoral because we have one biopsy post injection, which is 6 weeks later, so we won't have the curves, but we'll try to do it systemically. To answer the second question, we don't have preclinical data on intraarterial administration because intraarterial on mice is quite complicated. They have need some fabrication in rats, but on mice it's quite challenging. But we have some experience on intratumoral by percutaneous injection in the tumors, and there is some data showing that you could promote a better response, probably due to the local exposure of your ipilimumab or anti-CTLA-4 antibody.
Philippe, do you have a question?
Yes, I have several questions. First of all, I'd like to congratulate Lambros and his team to be able to put on the way this kind of study. Really, my congratulations for that. And I have a couple of questions. The first one is probably very interesting for all participants. It's a fantastic design. We know the importance of interventional oncology for immune therapies, but how can you start this kind of study? What is checkpoint inhibitors are not very cheap, are quite expensive. How do you address the financial aspect of this kind of study? How can you help us to start this kind of study?
Thank you very, very much. And indeed, it's very complicated and challenging for us interventional radiologists to get in this immunotherapy world and be able to put together trials. And this is something that we have not very well anticipated. The price of the antibodies is actually very, very expensive. So we did the first budget, supposing that it will be okay, and we will have the funding and all the treatments by the pharmas, which did not happen. So we had to pay for the treatments. And so it's a quite very, very big extra line that you need to add to your budget. And I'm very lucky in our institution because I have a lot of support by the immunological team and all this intratumoral immunotherapy group. We have a HITIT group, Human Intratumoral Immunotherapies group, which is very pushy and wants to put on trials. So they're very helpful. We have done some crowdfunding, so we had a lot of private donations. The Gustave Roussy Institute, the foundation of Gustave Roussy, helped us a lot. We went and have some financial support from scientific societies, from the French Society of Abdominal Imaging. We went and get some funding from the foundation of BMS, but still the cost and the budget of the study are pretty much higher than what we used to do with just with interventional oncology procedures, when the needles or the procedure can be expensive. Here you need to take into account the cost of long-term treatments, and yeah, it's very challenging. But still, I think it's worth to be part of that by proving that interventional radiology has a role to play with all these immunotherapy trials. And of course, systemic immunotherapy is coming to BCLC patients, but interventional radiology is moving also to the systemic world and the administration of these treatments.
Lambros, so, we all know that checkpoint inhibitors are a new fantastic therapy, but they are not for all patients. And I look very interesting and very enthusiastic at your slides, of course, but I didn't find any research of biomarkers before including a patient. Is that something that is important to assess for this kind of study?
Yeah, actually, indeed, the predictive and the prognostic biomarkers, it's a whole field that is lacking for immunotherapies. And the translational part of the study is also very important. So we will be able to correlate the sampling with the outcomes of the patient. So we'll have the answer probably for the next studies on. And because we love imaging and we think that probably interesting biomarkers will come from the imaging world, so I think the immunopet part of the study, which of course will be done once we have find the right dose for these patients, will be very interesting. If we can predict the distribution of the antibody and correlate it to the efficacy, maybe we will have a biomarker prior to treated patients. And what's interesting is to be able to predict the response before starting a treatment, and don't wait the first or the second evaluation. So yeah, the translational part will be very exciting also.
Can I ask you what's an immunopet? What do you mean by that? It's immune response evaluated by FDG-PET, or is it a new antibody against M2 macrophage or whatever?
I'll take option B. So actually, what we're trying to do is to tag, to radio label part of the antibody that we're injecting, and to be able to monitor the distribution. So you radio label a very small fraction of the antibody. So you take 1%, 100 micrograms or 1 milligram of your antibody, of your dose. You radio label it with zirconium or copper or fluoro. And then you do a PET imaging, could be PET CT or PET MR, and you evaluate the distribution. And hopefully the cold tumors, the PET not avid tumors, will be the immune cold tumors that won't respond to the treatment. And probably for those patients, there could be a rationale to go and intensify the treatments, either by doing local treatments, but also by injecting locally your treatment to bypass, to overcome this immune resistance. So it's coming. There are some papers that showing that immunopet labeling of the either the treatments or the cells, the immune cells, could predict this responding.
So thank you very much. Thank you very much, Dr. Tselikas Lambros, for this fantastic short lecture, but the quality is important. Thank you very much. I really congratulate the team to be able to make this kind of study, and I'm sure that we all have a large number of questions, but we will come to you back. Thank you very much.
Thank you very much. Thank you very much for the invitation. I'm very happy to have shared that with you, and hopefully we'll show you the results in the next ECIO meeting